quiet. Okay, we're live. Papalitan ko lang yung link, okay? Wait. Okay, dyan nakita may link.
Saan, sir, sinend po?
Nasa chat box.
May hinder.
Okay, dyan nakita may link.
Saan,
Okay.
sir, sinend po?
Chat box. Chat box.
May hinder.
Dyan nakita may link. Na-access mo na?
Yes, sir.
Okay na.
Okay po.
Okay. So we can start?
Yes, Mr. Chairman.
Okay, so good morning, everyone. So it's our first conference since the ECQ. Welcome to our Monday conference. So before we start, may I ask Dr. Margot to lead us in prayer.
Good morning po. Okay, let's bow our heads and put ourselves in the presence of the Lord. In the name of the Father, of the Son, and of the Holy Spirit. Amen. Direct, O God, we beseech you, all our actions by your holy inspiration, and help them on by your gracious assistance, so that every prayer and work of ours may begin with you, and by you be happily ended. We also include in our prayers the eternal repose of the soul of Dr. Resurrection and Dr. Melanio Cruz. May eternal rest grant unto them, may the souls of the faithful departed, through the mercy of God, rest in peace. Heavenly Father, you are the God of all comfort, who comforts us in time of need, and we pray that for those that are facing such a difficult trial today, uphold them, we pray, and ask that you draw very close to them. Raise up, we pray, the right people to minister to them, and to be a genuine comfort and support at this time of tragedy and grief. In Jesus' name we pray, Amen. In the name of the
Amen.
Father, of the Son, and of the Holy Spirit. Amen.
Thank you, Margot. So for this Monday, we will be discussing thyroid masses. And we are lucky to have with us Dr. Ravel Bartolome, our head and neck surgeon. And to moderate this morning session, may I call on Dr. Apollo Trinidad, our training officer.
Good morning, everybody. Welcome to our Monday conference. For the first speaker, with regards to introduction to the thyroid nodule and thyroid cancer, please welcome Dr. H. Mendoza. Richie?
Yes, sir. Sorry po. So, good morning. For our objectives today, to review the profile of thyroid nodules, benign versus malignant, to discuss the diagnostics, role of FNAC and molecular testing, to discuss the surgical options for differentiated thyroid carcinoma, to discuss the prognosis and surveillance, to discuss the recurrence risk factors, and to present a case. So for a brief introduction, I will be discussing a little physiology. So the hypothalamus, normally, the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and then releases thyrotropin releasing hormones into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. So the anterior pituitary then releases thyroid stimulating hormone, also called the thyrotropin or simply TSH. Then TSH stimulates thyroid gland, which is a gland located in the neck that looks like two thumbs. Okay. So the thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. So your follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, your triiodothyronine or T3 and thyroxine or T4. So once it is released from the thyroid glands, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted into T3 and it can exert its effect. So T3 speeds up the cell's basal metabolic rate. So as an example, the cell might produce more proteins and burn up more energy in the form of sugars and fat. And T3 increases cardiac output, stimulates bone resorption, thinning out the bones, and activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. So now, hyperthyroidism can happen in a few different ways. All of them result in too much thyroid hormone and a hypermetabolic state where cellular reactions are happening faster than normal. So the most common primary cause is Graves' disease. It is an autoimmune disorder where B cells produces antibodies against several thyroid proteins. These autoantibodies include thyroid stimulating immunoglobulins, which binds to the TSH receptor on follicular cells and imitate TSH. This results in growth of the thyroid gland and stimulates the follicular cells to produce excess thyroid hormone. So another primary cause is toxic nodular goiter, where one or more follicles starts generating lots of thyroid hormone. In some cases, it's because of a mutated TSH receptor that inappropriately keeps these follicular cells active. So a different cause is a hyperfunctioning thyroid adenoma, where follicular cells starts growing uncontrollably, forming a benign tumor and making excess thyroid hormones. So a secondary cause of hyperthyroidism is when a healthy thyroid that generates a lot of thyroid hormone in response to TSH secreting tumor in the anterior pituitary. So common symptoms of hyperthyroidism are weight loss despite increased appetite due to the increase in basal metabolic rate. Next is heat intolerance because the body is producing more heat. And lastly, rapid heart rate, sweating, hyperactivity, anxiety, and insomnia due to the effects of thyroid hormones on sympathetic nervous system. So a thyroid storm is a life-threatening complication of hyperthyroidism where the body undergoes a state of severe hypermetabolism. It can develop when someone stops their treatment, develops an infection, or has surgery. All the normal symptoms of hyperthyroidism becomes exaggerated. Examples are when heat intolerance turns into high fever, rapid heart rate turns into cardiac arrhythmia. So diagnosis is done by measuring blood levels of TSH, T3, and T4, and radioactive iodine uptake test and thyroid scan can help determine the cause. So treatment varies based on cause. So beta blockers to treat immediate symptoms, anti-thyroid drugs, which blocks thyroid hormone production and release, iodine therapy partially or completely destroys the thyroid function, and lastly, thyroid surgery. So for hypothyroidism, it is a syndrome of deficient circulating levels of hormone. Causes can be autoimmune or your Hashimoto's thyroiditis. It is an autoimmune disorder and it is the most common cause of hypothyroidism. It is caused by cell-mediated destruction of thyroid cells, B-cell mediated production of antibodies which are directed against three main antigens, your thyroid globulin, thyroid peroxidase, and TSH receptor, and less commonly the sodium iodine transporter. So iatrogenic causes of hypothyroidism could be due to complete removal of the thyroid gland, radioactive iodine therapy, and use of anti-thyroid drugs. So other causes are inflammatory such as subacute thyroiditis or giant cell thyroiditis. These are usually caused by acute inflammation caused by viral infections. Next is radial thyroiditis, where replacement of all or part of the thyroid parenchyma by fibrous tissues and it invades into adjacent tissues. Lastly, congenital due to thyroid dysgenesis or dyshormogenesis, a metabolic cause such as iodine deficiency. So symptoms for hypothyroidism are weight gain, cold intolerance, bradycardia, and cardiomegaly. In severe forms, mixed edema. So diagnosis is done by measuring blood levels of TSH, T3, and T4, and its treatment is by replacement of thyroxine. So for thyroid nodules are a common clinical problem. Epidemiologic studies have shown that prevalence of palpable thyroid nodules to be approximately 5% in women and 1% in men living in iodine-sufficient parts of the world. 40 to 50% incidence of occult nodular thyroid disease. There are 10 to 20% occult solitary nodule in asymptomatic patients, and 4 to 5% of nodules general population is malignant. Solitary nodule is usually malignant in 5 to 20% of patients. The solitary nodules are worse than multinodular. So thyroid cancer, it is the most common endocrine malignancy that requires surgery. It has a lifetime risk of thyroid carcinoma in 1.2%, and it is the fifth most common cause of malignancy in women. 95% of thyroid cancer in Philippines are well-differentiated carcinomas. So, a study done in PGH shows the distribution of malignant thyroid pathologies in the Philippines, showing that 84% are papillary carcinoma, 12% are follicular carcinoma, 0.63% are medullary carcinoma, and 0.25% are Hurtel cell carcinoma, and 1.9% are anaplastic carcinoma. So with the discovery of a thyroid nodule, a complete history and physical examination focusing on the thyroid gland and adjacent cervical lymph nodes should be performed. So pertinent historical factors predicting malignancy include a history of childhood head and neck radiation therapy, total body radiation for marrow transplantation, exposure to ionizing radiation from fallout in childhood or adolescence. Next is familial thyroid carcinoma or thyroid cancer syndrome. And there is presence of rapid growth of nodule and hoarseness. So pertinent physical findings suggestive of possible malignancy include vocal cord paralysis, cervical lymphadenopathy, and fixation of the nodule to the surrounding tissue. So for the major histology type, there's well-differentiated and poorly differentiated. In well-differentiated, there's your papillary carcinoma and your follicular carcinoma. And for poorly differentiated are your medullary and your anaplastic. So papillary carcinoma accounts for 80% of all thyroid malignancy in iodine-sufficient areas and is the predominant thyroid cancer in children and in individuals exposed to external radiation. It occurs more often in women with a 2:1 female to male ratio, and the mean age at presentation is 30 to 40 years old. So most patients are euthyroid and present with a slow-growing painless mass in the neck. Lymph node metastases are common, and in parathyroid carcinoma, they have an excellent prognosis with a more than 95% 10-year survival rate. So follicular carcinomas account for 10% of thyroid cancers, and it occurs more commonly in iodine deficient areas. Women have a higher incidence with a female to male ratio of 3:1 with a mean age at presentation of 50 years old. So follicular cancers are usually present as solid thyroid nodules, occasionally with a history of rapid size increase and long-standing goiter. Pain is uncommon unless hemorrhage into the nodule has occurred. So large follicular tumors that are greater than 4 centimeter in older men are more likely malignant. So malignancy is defined by the presence of capsular and vascular invasion. The cumulative mortality from follicular thyroid cancer is approximately 15% at 10 years and 30% at 20 years. Poor long-term prognosis is predicted by age over 50 years old at presentation, tumor size that is greater than 4 centimeter, higher tumor grade, marked vascular invasion, and extrathyroidal invasion and distant metastasis at the time of diagnosis. So this is a study done in PGH for well-differentiated thyroid carcinoma. A total of 728 patients diagnosed with well-differentiated thyroid carcinoma by final histopathologic biopsy were included in the study. The vast majority of cases were diagnosed as papillary thyroid carcinoma with only 79% cases of follicular thyroid cancer. Females were disproportionately affected, 84.9%, in both groups. The mean age at diagnosis was 44 plus or minus 13 years age, ranging up 18 years old to 82, with a majority of cases occurring in the younger age group of less than 45. So thyroid cancer incidence was distributed normally across age groups, with the highest incidence seen among 41 to 50 years old. So palpable lymphadenopathies at presentation were observed more often among cases of papillary thyroid carcinoma, while distant metastases at presentation were more common in patients with follicular thyroid carcinoma. So lungs appeared to be the most common site of distant metastases in papillary thyroid carcinoma, while bones and scalp were predominant in follicular type. So concomitant lymphocytic thyroiditis were reported in some cases of papillary thyroid carcinoma. Okay. Hertel carcinomas account for approximately 3% of all thyroid malignancies, and it is considered as a subtype of follicular thyroid cancer. Hertel cell tumors differ from follicular carcinomas in that they are more often multifocal and bilateral, about 30%, and are more likely to metastasize to local nodes, 25%, and are associated with higher mortality rate, about 20% at 10 years. For our poorly differentiated carcinoma, the medullary carcinoma accounts for about 5% of thyroid malignancy and arises from parafollicular or cells of the thyroid. Most medullary carcinoma occurs sporadically with a female to male ratio of 1.5:1, and most patients present 50 and 60 years old. Medullary carcinoma typically are unilateral, 80% of the time, in patients with sporadic disease and multicentric in familial cases, with bilateral tumors occurring in up to 90% of familial patients. It has a 10-year survival rate of approximately 80%, but decreases to 45% in patients with lymph node involvement. So survival is also significantly influenced by disease type. It is best in patients with non-men familial medullary carcinoma, followed by those with MEN2A and those with sporadic disease. Prognosis is the worst, with a survival rate of 35% at 10 years in patients with MEN2B. So anaplastic carcinoma accounts approximately 1% of all thyroid malignancy, and women are more commonly affected and is usually present in the 7th to 8th decade of life. The typical patient has a long-standing neck mass which rapidly enlarges and may be painful. The tumor is large and it may be fixed to the surrounding structures. This tumor is one of the most aggressive thyroid malignancy with few patients surviving 6 months beyond diagnosis. So treatments are usually cytotoxic chemotherapy and adjuvant radiation and palliative surgery. Lastly, lymphoma account for less than 1% of thyroid malignancy, and most are the non-Hodgkin B cell type. So most thyroid lymphomas develop in patients with chronic lymphocytic thyroiditis, and patients usually present with symptoms similar to those of patients with anaplastic carcinoma. Although it is a rapidly enlarging neck mass, it is often painless. So they usually respond rapidly with chemotherapy, the CHOP, your cyclophosphamide, doxorubicin, vincristine, and prednisone, which is also associated with improved survival. So combined treatment with radiotherapy and chemotherapy is often recommended. And surgery is only done to alleviate symptoms of airway obstruction. And it has a overall 5-year survival rate, 50%. However, patients with extrathyroidal disease have markedly lower survival rates. So for the next reporter, Dr. Francisco.
If you have any question, please write that in our chat box and we'll try to answer that after the presentation. Dr. Francisco, are you ready?
Yes, sir. So good morning. I will discuss about the diagnostic exams you should request when evaluating a thyroid nodule. So first, the initial evaluation of a patient with a thyroid nodule is to request a serum TSH and or thyroid hormone should be measured. So the most useful laboratory test for initial evaluation of nodules is serum TSH. Then next is we request an ultrasound. So why ultrasound? So high resolution thyroid ultrasound is the most sensitive and accurate imaging technique for detecting thyroid nodule, measuring dimensions, identifying structures, and evaluating diffuse changes in the thyroid gland. So thyroid ultrasound is the initial imaging modality of choice and should be performed in all clinical apparent or incidental discovered thyroid nodules. If with neck adenopathy is palpated on physical examination, also an ultrasound of the neck is warranted. So here are the features of ultrasound which is associated in malignancies: microcalcification, hypoechogenicity, irregular margins, a shape taller than wide. So features with the highest specificities for thyroid cancers are microcalcifications, irregular margins, and tall shape. So the number one question is, can surgeons do an ultrasound? So based from journals, which is published last January 2013, there were moderately studies that routine use of ultrasound by surgeons is effective in managing gallbladder and head and neck cases. So when to do a biopsy? Of course, when you have a suspected thyroid nodule, you should request a TSH. Next is the ultrasound. So remember, patients with known or suspected thyroid nodule should be requested ultrasound. Next is with multiple thyroid nodules more than 1 cm should be evaluated in the same fashion as patients with a solitary nodule more than 1 cm. Next is when multiple nodules more than 1 cm are present. So doing a biopsy will all depend on your ultrasound result, which is classified into 6. So high suspicion, which has more than 70 to 90% malignancy rate. Intermediate suspicion, which is 10 to 20%. Low suspicion, 5 to 10%. Very low suspicion, less than 3%. And then benign, less than 1%. So this is from ATA guidelines. No? So if you are high suspicion, you have a solid hypoechoic nodule or solid hypoechoic component of a partially cystic nodule with one or more of the following features. No? Irregular margins, microcalcifications, taller than wide, with evidence of extrathyroidal extension. Next is intermediate suspicion, hypoechoic solid nodules with smooth margin without microcalcifications or extrathyroidal extension. Next is a low suspicion, isoechoic or hyperechoic solid nodule or partially cystic nodule with eccentric solid areas without microcalcification, irregular margins, or extrathyroidal extension. Next is very low suspicion, which is a spongiform or partially cystic nodules without any sonographic features described in low, intermediate, or high suspicion patterns. Next is benign, which is purely cystic nodules. So based from NCCN guidelines, also they have sonographic features. No? So with solid nodule, with suspicious sonographic features, the threshold for doing a fine needle biopsy is more than more than or equal to 1 centimeter. Without suspicious sonographic features, the threshold for biopsy is more than 1.5 centimeters. Next is mixed cystic solid nodule. So with suspicious sonographic features, with solid component more than 1 cm. Then suspicious sonographic features without suspicious sonographic features, solid component more than 1.5 centimeters. So spongiform nodule more than 2.0 centimeters and a suspicious cervical lymph node. You should do a biopsy on the node and associated thyroid mass. So according to the PCS, PSGS guidelines, so it is established that the fine needle biopsy is reliable and safe and has become an integral part of thyroid nodule evaluation. So here's the summary. When to do a biopsy. So in high suspicion pattern, remember, no, sonographically suspicious sub-centimeter, less than 1 cm thyroid nodule, without evidence of extrathyroidal extension or sonographically lymph nodes. So observation with close sonographic follow-up of the cervical lymph node is done rather than pursuing to do an biopsy. So next is a benign suspicion or no nodule meeting biopsy size cutoff, which is purely cystic nodules and are very unlikely to be malignant. Aspiration is done. Next, so fine needle biopsy, remember, it is a procedure of choice in evaluating a suspicious thyroid nodule. However, it has limitation. No? It is highly sensitive on all thyroid nodular masses except in diagnosing follicular carcinoma. It cannot demonstrate vascular or capsular invasion. Next is inadequate sampling. So we also evaluate the cervical lymph nodes. No? So these are the features of a malignant involvement. So we have microcalcification, cystic aspect, peripheral vascularity, hyperechogenicity, and round shape. So if the ultrasound detects a cervical lymph nodes that are sonographically suspicious for thyroid cancer, we should do a fine needle biopsy of the suspicious lymph node. So here are the indications which warrants an ultrasound-guided fine needle biopsy. So non-palpable, more than 50% cystic, posteriorly located. And then obese patient, men with fully developed muscles, neck muscles, and then multinodular goiters. Next is we now go on to the cytology or the Bethesda system. No, it is classified by the ATA into non-diagnostic or unsatisfactory, benign, atypia of undetermined significance or follicular lesion, follicular neoplasm or suspicious for a follicular neoplasm, suspicious for malignancy, and malignant. So in a non-diagnostic cytology for a nodule with an initial non-diagnostic result, biopsy should be repeated with ultrasound guidance and if available, on-site cytologic evaluation. Next is repeatedly non-diagnostic nodules without a high suspicion of sonographic pattern, it may require a close observation or surgical excision for histopathologic diagnosis. Next is if repeatedly the result is a non-diagnostic, so surgery should be considered. So in benign cytology, if the nodule is benign on cytology, further immediate diagnostic studies or treatment are not required. However, given in the low false negative rate of ultrasound biopsy cytology and much higher yield of missed malignancies, no? Nodules with high suspicion ultrasound pattern, we will repeat ultrasound and ultrasound guided biopsy within 12 months. Then with nodules with low to intermediate suspicion ultrasound pattern, repeat ultrasound at 12 to 24 months, and then continue if sonographic evidence of growth, no, with minimal increase of 2 millimeter or more than 50%. Then next is development of new suspicious sonographic features. The biopsy could be done or observation can be done also with continued repeat ultrasound. So next is if you have a cytology of atypia of undetermined significance, you should repeat your biopsy because it will yield 70% malignancy rate. So next in managing follicular neoplasm or suspicious for malignancy, you should consider doing a surgery and molecular testing is suggested by ATA guidelines. So why? Because it will show a 70 to 90% malignancy risk if you have a follicular neoplasm, suspicious for follicular neoplasm, or suspicious for malignancy. Next is for malignant cytology, of course, surgery is warranted. And in cases of some indeterminate cytology, no, thyroid lobectomy is recommended as initial management. So molecular testing, is there any role for us to do a molecular testing prior in diagnosing a thyroid nodule? So molecular testing is a gene classifier of a BRAF mutation analysis. It is used for diagnostic and doing a prognostic or predictive purposes. Its advantage, it improves the patient outcomes sufficiently to justify its incorporation to clinical practice. And then it is used for diagnostic, ruling out or in the presence of thyroid malignancy, no? The follicular or undetermined significance, with the implication of a companion use to inform decision-making on primary surgery treatment. However, its disadvantage is there is no single optimal molecular test to rule in or rule out a malignancy. So in summary, our initial diagnostic tools to be requested is one is to do a serum TSH plus an ultrasound. Next is to do a fine needle aspiration biopsy. So thank you.
Thank you, Dr. Francisco. For our next reporter, may we call on the Chief President, Dr. Francisco. Jen,
Sir?
start, Jen.
Okay po. So, good morning, everyone. I will be giving a brief overview of the management options of well-differentiated thyroid carcinoma. So, the goals of the initial treatment for us surgeons are to improve the overall and disease-specific survival, to reduce the risk of recurrence and morbidity, and to permit
Jen,
accurate.
Jen, di ka naka-share screen.
Sorry, sir. Hello, can you see my screen, sir?
Yes, pero wala pa yung
Okay.
presentation. Yan, okay. Okay.
Okay, sir.
Yeah.
So, yes, I will start again, sir. So, for the goals of the initial treatment, the surgeon should be able to improve the overall and disease-specific survival of the patient, to reduce the risk of the recurrence and morbidity, and to permit accurate disease staging and risk stratification. So we have to get the primary tumor, even those tumor beyond the capsule of the thyroid, to get the lymph node metastasis, and to decrease the recurrence by giving RAI treatment and TSH suppression. And also, this a big factor to have a successful outcome is the surgeon's expertise. So first, I will be discussing the role of lobectomy. So based on the recent guidelines of the ATA, the indications are the following. For as long as the tumor is less than 4 cm and it has no extrathyroidal extension, there is no lymph node involvement, and the disease is unifocal, lobectomy is sufficient. So what does the evidence say? The overall and the cause-specific survival rate for the patients undergoing lobectomy versus total thyroidectomy has no difference in 10-year overall survival. Another evidence is done by Mendelssohn et al. And it was found that there is no difference in overall survival or disease-specific survival in a comparison of total thyroidectomy and lobectomy. Although most of the papillary thyroid cancer is multifocal, meaning to say it can appear in either side of the lobe, the result is still the same in terms of the overall survival rate. For as long as the criteria are met, the tumor is less than 4 cm and there are no evidence of extrathyroidal extension and lymph node invasion, lobectomy is sufficient. So what is the role of total thyroidectomy? These are the indications. And before, the gray area used to be the tumors which have a size of 1 to 4 centimeter. So the guidelines is saying that if the patient is more than 45 years old, if there are nodules, if there are history of thyroid cancer, total thyroidectomy should be done. Now, in the role of neck dissection, still the prophylactic lymph node dissection is still not recommended. And presently, what we know about this is that the compartment-based treatment is not necessary for thyroid cancer. So all therapeutic lymph node dissection, in this case, there should be a biopsy-proven cervical lymph adenopathy. So another paper has shown that there is no improvement in long-term patient outcome if you do a prophylactic neck dissection. So some indications for this are the following. So it's still found to be not beneficial for clinically negative lymph nodes. So for the completion thyroidectomy, this is usually done when a diagnosis of malignancy is made after the initial surgery. So it will provide complete resection of the multicentric disease, which will make RAI therapy efficient. And some studies are saying that RAI can replace completion thyroidectomy. Although there are still limited data, it can be used as an alternative. So these are some indications for completion thyroidectomy. So that's the end of my part, sir.
Thank you, Jen. For our next reporter, uh, may we call Tabil.
Apol?
Yes, sir.
Yes, sir.
Apol? Mamaya na ba yung question and answer o ngayong
Yes, sir.
input?
Pwede na po isulat sa chat box, sir. Tapos, we will try to answer that later.
Okay, sige, thank you. Sige, later na lang kamo.
Yes, sir.
So good morning, everyone. This is the part of thyroid cancer survivorship and fundamentals. So in contrast to most malignancies, where the focus and endpoint is survival, the endpoint here is the recurrence. Recurrence of papillary thyroid cancer after optimized surgery requires full understanding of the disease, what comprises the optimized surgery, and different types and implications of disease relapse that can be encountered. So papillary thyroid cancer is actually highly curable in about 85% of cases because of its innocent biologic behavior. So disease epidemiology of papillary thyroid cancer according to the American Cancer Society were as follows. Peak onset ages 30 to 50 years old, more common in female with a 3:1 ratio. Tumor less than 1.5 centimeter is a good prognosis, and age, patients less than 55 years old has a better prognosis compared to more than 55 years old. So overall survival in a study conducted in the Department of Surgery in Kuma Hospital in Japan in January 2018, the 10-year survival, the 15-year survival, and the 20-year overall survival rates were as follows. 10-year survival, 97%, 15-year survival is 95%, 20-year survival is 90% respectively. So there are, however, several clinical pathological features that predict a poor prognosis. Some of these features, namely the older age, as mentioned earlier, more than 55, distant metastasis, presence of lymph node metastasis, more than 3 centimeter, extrathyroid extension, tumor size of more than 4 centimeters, and for the surgical post-surgery completeness of resection have been adopted. So they have mentioned in this study, they mentioned that most important prognostic value for survival is the age and also the presence of distant metastasis at the time of diagnosis. So as a result of for the recurrence, disease recurrence or relapse, it can occur individually or in combination in the form of lymph node metastasis and local recurrence or distant or also as distant recurrence. So as a result of three technological advances such as high resolution ultrasound, TSH, and thyroglobulin, disease relapse can be discovered when it is subclinical. So, first, lymph node metastasis. It is estimated that 90% of disease recurrence or relapse in papillary thyroid cancer is lymph node metastasis. Relapse is typically identified within the first 3 to 4 years. So this is most likely represent disease persistent with possible enlargement rather than true recurrence. So this is actually well defined, and most often with absence of significant extranodal spread, lymph node metastasis can be excised precisely without need for either resection or damage to surrounding structures. So 57 of which were less than 3 millimeter in size and misjudged in about 80% to be negative. So next is the presence of true or local recurrence. So this is actually defined as newly formed disease found within the soft tissue. So often densely attached or invading these structures. So this one makes surgical resection more difficult and potentially involving sacrifice of important surrounding structures such as recurrent laryngeal nerve, tracheal cartilage, and other surrounding structures. So this is a reflection of a more virulent disease that mirrors the initial aggressive thyroid cancer. So this table demonstrates the analysis of variables for overall survival. The study adopted the clinical features of the following. The variables mainly, or the characteristic variables, the gender, older age, distant metastasis at the time of diagnosis, extrathyroid extension, the tumor size, more than 4 cm and 2 to 4 centimeters, clinical node metastasis, and extra node tumor extension. So in analysis of this table, older age and distant metastasis in particular had much higher hazard ratios than other variables. So for the overall survival, this figure represents the curve for patients post-op. So the 10, 15, and 20-year overall survival rates post-surgery were as follows. So 97% 10-year survival, 95% 20 years and 15 years, and 90% for 20-year survival respectively. So for the conclusion, advanced age, um, advanced age more than 55, distant metastasis, lymph node metastasis, presence of extrathyroidal extension, tumor size of more than 4 centimeters, and completeness of resection were actually significantly affect the prognosis of the patients. So that will be the last slide for my part. Thank you. Thank you. Were actually significantly affect the prognosis of the patient.
Okay, for the next reporter that we will be discussing about the surveillance, may we call on Dr. Magnaga.
Good morning, everyone. I'll be talking about the surveillance.
Odds, please share your screen.
Dr. Trinidad, mukhang nag-hang siya. Maybe you can go on with the question and answer.
Okay. Do you have any question? Please unmute your mic, then you can answer your question. Ayan, okay na pala. Can we proceed, Dr. Ong?
Sige. Later na lang. Sige.
So for the long-term management of advanced cancer management guidelines, there is a surveillance for possible recurrence in patients thought to be free of disease, which is a major goal of long-term follow-up. The second goal of the long-term follow-up is to monitor thyroxine suppression or replacement therapy to avoid under-replacement or overly aggressive therapy. So what is the recommended post-op surveillance for patients with WDTC, or what we call as differentiated thyroid cancer? So these are from the PCS guidelines, which is an evidence-based practice guidelines on thyroid nodules. They are saying that what we have to monitor post-op are the following: serum thyroglobulin, serum TSH, thyroid ultrasound, and whole body scan. And the major is to detect recurrence as early as possible. Now they're saying that if the initial treatment was a total thyroidectomy and a radioiodine ablation, then it is important to monitor the following: serum thyroglobulin, whole body scan, and a neck ultrasound. So these these surveillance is based on the characteristics after the initial surgery and remnant ablation. Based on the risks, low risk would be those that have no local or no distant metastasis. All macroscopic tumors have been detected after the initial surgery. And then we also have no tumor invasion of local regional tissues or structures. We also make sure that the tumors have no aggressive histology. And iodine is given, no uptake outside the thyroid bed on first treatment. There's also an intermediate risk wherein a microscopic invasion of tumor into perithyroidal soft tissue at initial surgery was seen with aggressive histology or vascular invasion, and high risk if it has a macroscopic tumor invasion. Now, the serum thyroglobulin in follow-up is the most important initial test to monitor patients of residual or recurrent well-differentiated thyroid cancer, and it should be measured every 6 to 12 months. Also, hello, serum thyroglobulin is also detected for those who undergone for those who have undergone less than total thyroidectomy, meaning those who have not are not subjected for total thyroidectomy and have a total thyroidectomy but not RAI ablation. Serum thyroglobulin is a must. And also a same strategy for follow-up is used based on serum thyroglobulin determination and a neck ultrasound at 9 to 12 months. Now, the serum TSH is recommended for post-operative surveillance of patients with well-differentiated thyroid cancer to determine the adequacy of suppression. And it should be monitored again every 6 to 12 months in the first year and then yearly thereafter. For the ultrasonography or neck ultrasound, it is recommended for post-operative surveillance to detect recurrence in the thyroid bed and cervical nodes, and should be monitored again every 6 to 12 months in the first year and then yearly thereafter. Now, based on the ATA guidelines, there is a strong recommendation with the moderate quality evidence, which is the strongest recommendation following surgery to evaluate the thyroid bed and central and lateral cervical nodal compartments. It is seen in cervical ultrasound, which is used or performed at 6 to 12 months and then yearly, as said earlier. But this would be depending on the patient's risks for recurrent disease and thyroglobulin status. This one is also a strong recommendation, but with low quality evidence, that suspicious lymph nodes at 8 to 10 millimeters in the smallest diameter should be biopsied for cytology with a thyroglobulin measurement in the needle washout fluid. And then lastly, the weak recommendation with low quality evidence. I think we would not be following, wherein suspicious lymph nodes less than 8 to 10 millimeters in smallest diameter may be followed without biopsy. Now, for the total body scan, it has a limited usefulness and it is not necessary in low-risk patients. A diagnostic whole body scan has limited usefulness in low-risk patients who are clinically free of residual tumor with undetectable serum thyroglobulin and for those who has a negative neck ultrasound. Likewise, it is not necessary if the thyroglobulin is elevated and ultrasound of the neck is positive, since there are other therapeutic options such as the surgery or RAI ablation that are already warranted. So although serum thyroglobulin and a diagnostic whole body scan have been previously considered complementarily in identifying residual tumors, an undetectable thyroglobulin alone has been found to sufficiently do this. That's why it is not really necessary for a total body scan in patients with differentiated thyroid cancer. Next, a positron emission tomography scan, or what we call as PET scan, is a valuable tool in detecting and localizing recurrence and metastasis in post-total thyroidectomy patients with negative whole body scans and elevated thyroglobulin levels. This now provides prognostic information for patients with differentiated thyroid carcinoma, and its use has grown because of its ability to localize lesions with high glucose metabolism. And also several studies have supported the use of PET scan as an important tool in detecting and localizing recurrences and metastasis in post-total thyroidectomy patients with elevated thyroglobulin levels and negative whole body scan, with a sensitivity of around 78% to 90% and specificity of 25 to 95%. Then we have a computed tomography scan or high resolution or helical CT scan. This one is useful in detecting lung metastasis naman in patients with detectable thyroglobulin and negative whole body scan. The integration of CT scan increases the diagnostic accuracy of PET scan in detecting metastasis in patients with differentiated thyroid cancer. We also advocate the usefulness of CT scan detecting pulmonary metastasis in patients with well-differentiated thyroid carcinoma. So there has been also a study by Ong et al. Investigating the utility of integrated PET scan in detecting recurrences and metastasis with elevated thyroglobulin levels in negative whole body scans showing a sensitivity of 88.2%. That ends my report.
Thank you very much for the next reporter, Dr. Hardikman. Hardip,
Okay, just a quick review. The extent of surgery for papillary thyroid with high-risk tumors or bilateral tumors, a total or near total thyroidectomy should be done. Thyroid lobectomy can be done on small tumors less than 1 centimeter, incidentally discovered or with low-risk unifocal intrathyroidal papillary carcinoma. Some studies will say that total thyroidectomy should be done for tumors more than 1 centimeters. And enlarged or obviously involved central nodes should be removed. According to 2009 ATA guidelines for thyroid carcinoma, prophylactic ipsilateral or bilateral dissection may be done on masses of T3 or T4, but no need for prophylactic neck dissection for T1 or T2 lesions that are clinically node negative. Biopsy-proven lymph node metastasis detected clinically or by imaging the lateral neck, a neck dissection should be done. So one study made by Muhammad et al. Showed that the type of surgery, the lobectomy versus total thyroidectomy, would not alter or doesn't have any significant difference in terms of overall survival rate. In that study, 61,000 patients were included in 1998 to 2006, ages from less than 45 to more than 65. So those patients had tumor size ranging from 1 to 2 centimeters and 2 to 4 centimeters respectively. This is their graph showing that the lobectomy and total thyroidectomy done in these patients did not alter the no significant difference in terms of proportion or survival rate. So at around 5 years, the post-op, the survival rate is more than 95 or up to 99%, with a decrease in survival rate, but still around 90% more than 10 years. So the lobectomy is shown with the continuous line, while the total thyroidectomy is the broken lines. So this graph just shows the sizes of the mass and the surgery done did not have a difference in terms of survival. So after talking about survival, we talk about the recurrence of the patient. So post-surgical patients should be monitored and should be classified based on how you saw it during the surgery, whether patient can have a low risk of recurrence, intermediate risk, or high risk. Those having a low risk of recurrence are patients who had no local or distant metastasis, wherein all macroscopic tumor were removed, no tumor invasion, no tumor with aggressive histology, and those who had no vascular invasion and clinically N0 or less than or equal to 5 pathologic and 1 micrometastasis. These patients had no intrathyroidal these patients have intrathyroidal encapsulated follicular variant, intrathyroidal well differentiated follicular thyroid cancer. So take note of these low risk patients. Then we have intermediate patients who had microscopic invasion of tumor in the perithyroidal soft tissues and have clinically positive lymph nodes and papillary thyroid cancer with vascular invasion. And those high risk had macroscopic invasion of tumor into the perithyroidal soft tissues, incomplete tumor resection, distal metastasis, post-operative serum thyroglobulin suggestive of distal metastasis, and others. So take note that post-surgical patients should be classified whether low, intermediate, or high risk so that they can follow up respectively or accordingly, or more judicious follow-up should be done. And lastly, this slide will just show the survival rates of patients undergoing surgery or had papillary thyroid carcinoma. Survival rate is good, with decrease in survival rate with increase in age. So survival rate is not affected by the type of surgery. That's what studies say. But recurrence rate will depend on what type of surgery or how surgery was done. So follow-up is important. Thank you.
For some case presentation, I will call on Dr. Ben David. Ben?
So good morning. Today I'll be, hello sir.
Yes, yes. Go ahead, Ben.
Good morning. I'll be presenting a quick presentation of colloid adenomatous goiter. So for the general date of the patient, we have a 37-year-old male who was seen at our institution with a chief complaint of an anterior neck mass on the left. So history of the present illness started 6 months prior to admission when patient noted the mass on his left anterior neck. 3 months prior to admission, patient noted as an increase in size, which is now accompanied with difficulty of breathing and swallowing. Patient sought consult at a different institution where he was diagnosed with colloid adenomatous goiter and was advised surgery, hence admission at our institution. So upon physical examination, pertinent physical exam, there was a firm 4 cm mass on the left anterior neck, which moves upon deglutition. So our assessment for this case was a colloid adenomatous goiter. So diagnostics done, an ultrasound was done which showed a complex predominantly cystic mass on the left thyroid lobe measuring 3 by 5 by 2.5 by 2 cm. There was also multiple nodules noted on the right, measuring 1.5 by 1.2 by 1 cm, which was a predominantly solid nodule, and a cystic nodule on the right as well, measuring 1 by 0.8 by 0.5 cm. So thyroid function tests were done, and TSH, T3, and T4 were all normal. Fine needle aspiration biopsy was done outside our institution, which which was negative for malignancy. So given that our assessment for this patient was multiple colloid adenomatous goiter based on the ultrasound. Indications for total thyroidectomy for colloid goiter would include compressive symptoms, cosmetic reasons, as well as if you are considering suspicious for malignancy. So for this patient, compressive symptoms were already present, so we decided to do surgery um, to do a total thyroidectomy. So the procedure for this patient was um, unremarkable. Patient was discharged 2 days post-surgery. So the final histopath showed multiple colloid adenomatous goiter both on the left and right lobes. So for benign thyroid diseases, once we do a total thyroidectomy, we can already proceed with thyroid hormone replacement therapy. So the usual maintenance dose ranges from 100 to 200 micrograms per day. So when starting your thyroid hormone replacement therapy, we can start with 100 micrograms per day, which we can increase by 50 micrograms per day once TSH levels has been checked every 4 weeks. So the target level for our thyroid stimulating hormone post surgery would be for a benign disease would be 1 to 2 microunits per liter. So as I've mentioned, for benign for patients who underwent total thyroidectomy, so TSH levels can be rechecked every 4 to 6 weeks to be able to check if you are on your desired thyroid hormone replacement medication. So that's my part for the report.
Okay, thank you, Ben. At this point, we will now be entertaining some questions from the audience. Dr. Acuña?
Yes. So, yung kay Ben, online ba si Bart?
Yes, sir. Yes, sir.
Oh, sige. I usually don't start my post-thyroidectomy levothyroxine with 100 agad. Usually, I start with 50. Please remember, Ben, that the dosing that you stated is for Americans. So imagine mo yung size ng Amerikano tsaka Pinoy. Usually yung 100 mataas yun sa Pinoy as a starting dose. Usually I start with 50. I don't know about Bart. Gusto ko madinig yung recommendation ni Bart.
Yeah, actually, for me, I start my patient at 100 microgram. Then titrate it towards around 150 microgram per day. Especially if my intention is just for maintenance. Usually, most Filipinos are okay at 100 microgram per day.
Okay, thank you.
Are there any more questions?
Regarding sa andyan naman online naman si Bart yung choice ng ano, how often do you choose lobectomy versus total thyroidectomy? Do you still do lobectomy alone?
First of all, I would like to commend all the presenters. Congratulations to all the presenters. You have given more or less a comprehensive reporting of how we manage or how we diagnose thyroid nodule in general. And I'm sure the students who are around can take note. Of course, those are technically lectures that were taken from journals, ATA recommendation, PCS recommendations, textbook. It's different when you're already applying it clinically. That's why, with regards to the question of Dr. Acuña, do I still practice lobectomy? Do I still practice although I technically do total thyroidectomy in all of my patients. Now, since my practice is head and neck surgical oncology, most of my patients that will be referred to me would be highly suspicious of malignancy. So I usually end up doing total thyroidectomy, but I would still do a lobectomy if it's indicated. As long as based on the lecture of the residents, less than 4 centimeters, unilobar, no clinically apparent cervical lymph nodes, no extrathyroidal disease. Majority of thyroid nodules that we see in clinical practice are still benign, and it's still advisable, or it's still recommended to do lobectomy unless you have an indicated for doing total thyroidectomy. The idea is still not to always condemn patients as having a lifetime hypothyroidism by doing total thyroidectomy in all. But if you have indication for total thyroidectomy, multinodular disease, whether benign or malignant, I will not hesitate doing total thyroidectomy. That's why the presentation of the residents are actually very, very good, and I would like to commend them. Siguro yun yung magandang nagawa ng quarantine, ano? Wala silang ginagawa, kaya nakapag-aral sila sa lecture nila. Congratulations, everyone.
Comment lang doon, Apple tsaka Rabel.
Yes, sir.
So, yung mga na-opera ko kasi ng lobectomy, yung first few years ng practice ko, yung mga early 2000s, many have come back with a compensatory hypertrophy of the contralateral, yung iniwan, the remaining thyroid gland, magko-compensatory talagang hypertrophy yun. And although even if they have they don't have nodules, the patients are bothered by the compensatory hypertrophy. That is why the same with Rabel, I seldom do lobectomy alone na eh. Number one, correct si Deep doon. I agree with Deep. Correct na, tama, ang survival, pareho lang. Pero yung recurrence, especially everybody knows that the chances of papillary thyroid cancer being bilateral and multifocal is up to 80%. Kaya magkakaroon ng nodule. Even if you biopsy the subsequent nodule on the previously unaffected site, even if you biopsy that as benign, patients are still bothered na may nodule doon sa kabilang side. That is why most patients, after explanation, most patients would be happy with a total thyroidectomy rather than have a completion thyroidectomy. Kasi in-explain ko sa kanila na talagang pwedeng magka-completion thyroidectomy in such cases. And they would rather have the total thyroidectomy versus the lobectomy alone.
If I may, Dr. Acuña, that's entirely a different story. A compensatory hypertrophy of the other one. It's an entirely different story indication that may warrant you to do a completion thyroidectomy, a lobectomy on the other side. What we are discussing is for its indication in multinodular goiter or well-differentiated thyroid cancer. It's always really a possibility doing a lobectomy to have a compensatory hyperthyroidism. It's really not also a frank indication unless there is compression because of hypertrophy. Then that's a different story. Even at such, if I would have patients like that on follow-up, enlarging thyroid gland on the other side after a lobectomy, as long as there are no nodules and the compression is not really well evident, I would not do a lobectomy on the other side. And I would just explain to the patient. The reason why we're not doing an outright total thyroidectomy for benign disease because it's obvious. It's not also benign to have a lifetime hypothyroidism or even the possibility of injury to the parathyroid and having a lifetime hypocalcemia. So that's one thing that I would want the resident, the student also would understand. So the rationale of outright doing total thyroidectomy on all is not because I am going to be afraid of having a compensatory hypertrophy. I'm going to do a total thyroidectomy as indicated if there is multinodular disease, whether benign or malignant, or or it's really malignant on both sides, or you really have an extra or you're thinking of multicentric disease, but not because of compensatory hypertrophy of the other side post-op. I will not use that as an indication for total thyroidectomy.
Yeah, I understand. Pero during the preoperative consultation with the patient, I will offer to them total versus ano. Siyempre, kailangan may indication. Hindi naman natin i-offer na. And I rarely operate on benign disease except for multinodular. So if we're fixed on kung cancer straightforward, kahit na one lobe, do you still offer lobectomy?
It really depends. No, that's why there are also indication for doing FNAC. If I have really an entirely unilobar disease, clinically benign, both by physical examination and by imaging, I will still do a lobectomy. Again, even I will not even explain to my patient. This is my own personal view because it's on table on discussion. I will not. I will probably say that there may be a compensatory hyperplasia of the other side, but I will still go more on patient not being rendered hypothyroid by doing total on all. So I will just do
I
total
agree.
as indicated. Yes,
I agree.
so
Pero
I will not use compensatory hypertrophy as an indication for total thyroidectomy.
yes, of course. Hindi lang naman compensatory hypertrophy, pero yung recurrence sa other
Yeah,
side.
yeah,
So
yeah. That's the
the
only
same
reason
with
why. The
the
only
same.
reason why I mentioned that is because your argument earlier is that most of your patients afterwards would have hypertrophy. So I just want
Hindi, sabi
to
ko, one,
make
isa
it
lang yun, isa
perspective.
lang yun. Oo.
Okay,
At pag,
thank you.
when you mention it to the patients, they would rather have the whole thyroid removed. In my practice, I always lay down all the options. I'm sure you do also. I lay down all the options and then I make them choose which one suits them better. Yung iinom ng gamot versus lalaki ulit, pwedeng operahan. Ayoko na po. That is why with using the same argument, rarely do patients want breast conservation surgery. It has the same, pareho lang ng analogy yun, at saka ng explanation sa patient. With the possible recurrence of a thyroid conservation surgery or breast conservation surgery, the patients would rather go for the total
Yeah,
mastectomy or thyroidectomy.
with all due respect, Bob, I don't want to compare breast conservation surgery with allobectomy. That's entirely different. The behavior is entirely different. So again, the reason why I made mention of the argument is because it will not be a question, especially for the resident in the oral exams, that an indication for a total thyroidectomy is the fear of having a compensatory hypertrophy. That's the only point that I would want to drive at here.
Hindi lang naman yung
Doctor,
Robel. Tapos last statement na to. Not only for the compensatory hypertrophy, but for the recurrence on the other side. Kasama yun. So,
Yeah,
thank you.
that's already given. Recurrence is what we would want to avoid if we would want to do the reason why we're going to do total thyroidectomy.
Thank you, sir. Dr. Bartolome, I want you to comment on a Japanese study with regards to microcarcinoma. That means less than 1 centimeter. Some of them will just do observation and frequent imaging studies.
Yeah, the same. That's why even if it was lectured or it was mentioned that FNAC and is the second step after ultrasound and TSH. Me personally, and also probably some head and neck surgical oncologists would not routinely do an FNAC if it will not really change what they're going to do as a management. So I have seen lately a lot of patients wherein radiologic clinical characteristics are really benign. I will not do an FNAC because I will either do a total or a less than total thyroidectomy, eventually finding out microcarcinoma, micropapillary carcinoma. then that's it. As long as you have done the surgery itself, whether lobectomy or total thyroidectomy, and you were able to catch the whole disease less than 1 centimeter, then you technically, I would usually manage the patient as of course, they will always be stage 1 thyroid cancer, or they are usually managed like a benign problem with regular surveillance by physical examination and radiology. No other additional treatment is necessary. Prognosis
Thank
would
you.
still be the same.
Yes, sir. Thank you very much for that clarification. Are there any more questions from the group? There were no questions asked in the chat box. So I guess, Chairman, we have discussed the thyroid nodules.
Apple?
Are there any more?
Yung molecular testing kasi laging binabanggit yan. Ano? So yung BRAF gene mutation. Hindi ko alam kay Rabel kung meron dito, pero I have asked the big hospitals here pero wala namang available. So it gives me so much pain that we always discuss this gene mutation studies sa mga convention, lalo na pagka sa PCS, American College, pag pumunta ka. Even in the United States, it's not widely available. But the speakers would always want them to embark on molecular testing. Even they would even embark on molecular testing on the needle aspirate to predict whether it would recur or would still need surgery. So, yun lang yun. So, as far as I know, walang BRAF testing dito. Kakatanong ko lang kanina umaga sa NKTI at saka St. Luke's bago tayo nag-meeting. Ewan ko lang kung si Rabel kung may alam siyang ibang meron.
Just like you, I don't know anybody here in the country, and it's still not being widely used anyway. Probably it's really more of still on its investigational phase for utility in prognosticating in the future, especially with now having more and more study on cell-targeted treatment for recurrent and unresponsive papillary and anaplastic thyroid carcinoma. So, yun lang siguro yung tulong niya at this particular point.
Thank you. Question pa, doon sa lecture ni Jen.
Yes, sir.
Oo. Kay Jen tsaka kay Rabel. Kailangan ba biopsy proven yung lymph node metastasis before you embark on a neck dissection, or is imaging and physical examination enough to indicate a neck dissection?
Yes, sir, based on the guidelines, sorry, sir. Based on the guidelines, sir, it was said there that it should be biopsy proven. I think frozen section would play a role in this situation, sir. But in our local setting, sir, there is already a good definition of clinically positive lymph nodes, sir. And we based our decision in neck dissection, sir, in the presence of a positive, in the presence of clinically positive lymph nodes, sir. Either preoperatively or intraoperatively, sir.
So ano yung clinically positive lymph node?
Yes, sir. A lymph node with a size of 1 centimeter, sir.
Sa PE?
Yes,
sa
sir.
ultrasound, ano yung suspicious sa ultrasound?
Ultrasound findings of a lymph node with signs of malignancy, sir, is having a round morphology and a loss of fatty hilum, sir.
Yeah, very good. Si Ravel, do you still, talaga bang kailangan natin i-biopsy proven o pwede na yung clinically proven?
Well, I agree with Jen, number one. Number two, I also agree that there are already guidelines available on how you're going to decide whether to do an indicated. Number one, that I want to inform the group. Up to now, we don't recommend a prophylactic neck dissection for well-differentiated thyroid cancer. When we say prophylactic, the size of the tumor is around T1, T2, no palpable lymph nodes. Now, because of high-resolution ultrasound, sometimes you may be able to detect occult cervical lymph node metastases on T1, T2 lesions or T1, T2 thyroid nodules. In that case, that is probably the indication wherein a cervical lymph node biopsy, ultrasound guided by FNAC may be indicated. But if you already have a T3, T4 lesion and you have a clinically or radiologically suspicious cervical lymph nodes, me personally and some others would not anymore do an ultrasound guided FNAC and proceed on doing the indicated neck dissection for those kind of tumors. So
Okay.
it's really case to case at this time. So kaya kanina nga
So,
ni-lecture din na it's not really also routine to do a ultrasound guided FNAC for clinically and radiologically suspicious cervical lymph nodes.
tama ba yung intindi ko? Pag T3, okay na yung clinical indication.
Yeah,
You don't do it.
As
Pero,
a general rule for most head and neck cancer, that's also what I'm trying to teach our resident. If you have a T3, T4, although and you have a radiologically proven cervical lymph nodes or a clinically palpable cervical lymph nodes, I will not recommend on already doing an FNAC on the lymph nodes because it will only how do you call that? It will only make decision making a bit confusing. The problem is you have a T3, T4 proven positive papillary, for example, and you did an FNAC of the cervical lymph node. It turned out to be inconclusive. What are you going to do? You will still do the indicated neck dissection. So if it's a T3, T4 tumor, bilateral at that, and then you have an ipsilateral, for example, say ipsilateral cervical lymph node, palpable, 1 centimeter, ultrasound proven with characteristics of metastasis, I will outright do neck dissection. If I have a T1, T2, only one side, my plan is probably just to do a lobectomy. But incidentally, you found out to have radiologically suspicious cervical lymph nodes. That's when I will probably ask for an ultrasound guided FNAC of the cervical lymph nodes.
kung kunyari, Bel, actual examples, ano? Kunyari, actually, yung isa ko, 1.5 yata yung tumor sa right side. Pero yung cervical adenopathy, bilateral na puro suspicious. So, what is your advice on
What
that
is
case?
what is the biopsy of the thyroid node? It's malignant.
Malignancy, PTC.
Okay, if that is the case, then I will do an ultrasound guided FNAC of the cervical lymph nodes.
Hindi ko na matandaan kung ilan yung actual. Pero kunyari, may tatlo sa kanan, ipsilateral, tsaka may dalawang kulani na suspicious sa contralateral. You do biopsy on all the 5 lymph nodes.
As long as it doesn't really matter whether you in that particular case, you just have to do a bilateral one on each side because you have to decide whether you're going to do a bilateral neck dissection. Because in this case, if it's a proven malignancy and you already have a proven metastasis, you will definitely do a total thyroidectomy. The next decision is am I going to do a bilateral neck dissection? So that's the reason why you need to do a biopsy of the bilateral lymph nodes.
Okay, thank you.
Okay, thank you very much for.
I will just
yes,
send,
sir, yes, sir.
I will just send the bill to Dr. Acuña later.
Okay, thank you very much for that lively discussion. For the closing remarks of this Zoom meeting,
Actually,
may we
na-opera ko
call
na
on
yung
the
patient.
chairman,
Tinanong ko lang.
Dr. Yong.
Joke lang.
Yes, good morning, everyone. Congratulations to all our presenters. Thank you, Dr. Bartolome and Dr. Acuña, for making this discussion lively. Let's just spend this last few minutes in honoring our two faculty who are already in the midst of our creator at the moment. And it's a great loss for the department. So I'd like to share a video honoring our two faculty. Okay, that's for June rest. Thank you, Dr. Resurrection. And this time, a moment for Dr. Melania Cruz. Okay, thank you very much for attending this Monday conference. So we've lost two of our great mentors. Always stay safe and healthy at this time of pandemic. Good morning, everyone.
Pupunta
Ingat,
ba kayo?
ingat. We'll see,
Thank you,
sir. We'll
Dr.
see.
Bartolome. Thank you.
Thank you everyone. Ingat. Bye-bye.
Thank you, sir.
Thank you.
Thank
Thank you.
you.
You po,
Bye.
stay safe. Thank you po.
75 participants
Stay
and
safe.
about 38 million
You,
viewers
you,
in YouTube. No?
you are all welcome to visit Antipolo. Come here.
Thank you, sir.
Paki-check yung mga pintuan. Nandyan yung breakfast nyo sa hinatid na.
Doorstep. Doorstep.
Bye-bye. Bye-bye, everyone. Bye-bye.
Bye,
Thank you.
everyone.
Good morning.